Okay, so we'll talk about evidence I think that is going to take some time. So we'll up till this point. If you have any questions, so we'll go through that and then we'll move around. So I can see the chat box is also full. Yeah, Dr. Chaman Aruj has raised his hand.
Hi, Vikas, and
Hi.
congratulations again for finally completing it. Good work. I just have a quick question. Is there
Yeah.
any a requirement of, as in like prerequisite specification that you have to work in your country as a consultant in that specific post where you are applying? Because like if I've done FCPS and I came here immediately after FCPS, I've not worked in my country as a consultant, but I
No,
do
there
have.
is. Yeah, sorry. Go on.
Yeah, please go ahead. Yeah, you got my
So there
question.
is no such requirement not written anywhere. So if you see the traditional training pathway, the CCT pathway, so the candidates, they do their training, they review their competencies everywhere, ST 1, 2, 3, 4, 5, 6, 7, 8, or whatever, and the next day they become consultant. So there is no requirement that after your postgrad qualification, you have to work as a consultant. It's not authentic.
Thank you. Perfect. Thank you.
Yeah.
Hi, can I ask a question?
Yeah.
Yeah, sorry. So before starting CESR, they say that you have to drop an email to GMC for them to send a CESR link. So is that the basic? I mean, that's the main important thing to start the CESR?
No, that is not an important. So you have to drop an email just to guide them. I mean, to get an guidance. So they will review your basic experience, and if your eligibility, if you care, if you because sometimes you don't have the eligibility. So to make sure that that is the case, they just ask you to drop an email, but that is also not a mandatory thing. I did not do any such thing, and I will directly proceed to my application.
Because the thing is that I can't find anything to start an application on the GMC online. So is that a GMC online which we have to use to start, or it's
Yes,
something
it's a
different?
GMC online. So you make a GMC online account if you have not already. And when you have made an account, then on the left panel, you can go to the tab of registration. When you click registration, the tab, it will further open a sub panel which will show applications, and you will find your previous general registration application there as well when you did PLAP or
Yes.
whatever you have route
Yeah.
you opted to come. And in that, it will further open that you want to start a new application. So you click
Yeah.
that start new application, and it will guide you further that what is this application for GP registration, for specialist registration, or for
Okay.
whatever. There are lots of other pathways as well. So GMC, it's very complex. So you can
Okay.
choose from that you want to start a CESR application, and I actually will endorse that you, if so if you have some evidence, and you think, if you foresee that you will be able to complete your CESR in the next 2 years, so you do start your application. You can
Okay.
always delete that application, because there is there's a condition of expiry after 1 year. So it doesn't matter, don't worry about that. Start your application, save it, whatever you have, and when it is expires, just delete that and start a new application and copy and paste from the previous. So you can do that as many times as you can.
Okay, so is there a compulsion that you have to work in that area for like 5 years? Like I'm going to apply for a subspecialty in neurology. So is that a compulsion that you have to work in that area for 5 years before proving the evidence?
No, there is no such compulsion that you have to work in an area for 5 years or so. Although I don't know about neurology, but I did not find any limit of any minimum years of experience anywhere. So I've explored the guidance thoroughly, but I didn't find anything in in a general pediatric guidance. At least I cannot say for sure for neurology. If
I can
anyone else.
actually clarify a little bit about there are a few questions about CESR in subspecialty. So these CESR applications are actually called as CESR in non-CCT sub specialties. So the one which Waqas is at the moment talking about is CESR in a CCT specialty, which is pediatrics. But if you are doing a application for pediatric subspecialties like pediatric neurology, neonates, community pediatrics, or pediatric emergency medicine, so that's the CESR in a non-CCT specialty. So there's a slightly different eligibility criteria for that. If I correctly remember, it should be on the GMC website and college website also, that you should have a overseas postgraduate qualification in that subspecialty, or overseas training experience, at least 6 months training experience in that subspecialty to be eligible to apply
Yeah.
for CESR in that subspecialty. So make sure if you are thinking about a CESR in subspecialty, that is a CESR in non-CCT specialty, go to the GMC website. They have got all the evidence or the guidance. What are the eligibility criteria for CESR in a non-CCT subspecialty?
Yeah.
Thank you for that, and I will confirm exactly what has been mentioned. For any subspecialty, neonates, emergency, or whatever, it is not an easy to be eligible, because for eligibility you need to be training both. For example, if you worked in pediatric neurology for 7 years in the UK, this is not eligibility criteria. Criteria, you have either degree on that pediatric neurology or training abroad in pediatric neurology. So
Yes.
Yeah.
Okay.
So I'll tell you something because I have a neurology interest as well. I'm working in pediatric epilepsy, and I'm planning to. I attended a BPNA conference last year, and there are other equivalent pathways in neurology as well, which are similar to that. So the best thing will be write to CSAC committee, so CSAC committee of the Royal College, that you want to work as a neurologist. Because I explored through the GMC website, there is up till now I couldn't find a all the subspecialties are not listed there. Peds, endo, gastroenterology. So it's not listed there. The detailed guidance is not there. And most of the non-CCT specialties, which are the pediatric subspecialties, the GMC asks for generic domains. They have 4 or 5 generic domains: team working, and communication, patient safety. So the 3 or 4 generic domains which you have to provide the evidence for. But there are a lot of other pathways available. When you come to work in UK, you can do PLAB, you can register on the basis of your postgraduate qualification, you can register through the sponsor, there's a MTI, a lot of other things. So the conference I attended for pediatric neurology, they told me, there was a person from the Royal College who is the chair of the CSAC committee of pediatric neurology, and you can write to them and they can direct you further.
Okay, that's really helpful, and congratulations again, Waqas.
Thank you. Another thing I will mention, if you want to work in neurology or in a DGH, you can still do that with the general pediatric CESR, and you can do a spin in epilepsy or neurology, but that will not be registered as a subspecialty register of the GMC.
Okay, thank you.
Okay, so I have not gone through all these questions. So anything, Sadia or Jamil, in the chat section?
So, I can see 2 hands up. Zainab and Hannah, have they been answered? Have you asked the question, Zainab and Hannah? Or the history?
No. So actually, my question is different. So first, congratulations, Waqas, for your successful application. The question, I may missed it in your presentation initially. Do the pediatric registrars, I mean, what the work in NHS as a pediatric registrar will help in supporting the CESR application, or it should be at the level of associate specialist or locum consultant?
No, 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 no. So you can work as a pediatric registrar or even a clinical fellow. That doesn't matter unless you get your competencies signed. So I will come to that. If you go through that's why portfolio is important. Because
Okay.
there's a checklist there, and when you get your checklist signed, it doesn't matter you are working as a clinical fellow or registrar or trust grade or associate specialist or a locum consultant. In fact, when you are working as a locum consultant, you will not get many opportunities to get your portfolio signed because you need a senior colleague to sign these competencies. But I'll come to that in detail in subsequent slides.
Oh, great. Thank you very much.
All
Yeah.
right. Hannah,
Hello.
Hannah, hands up. Hannah, you want to go first? Is it a history hand? Okay. Abda is the next one. Do you got a
Yes,
question?
hi. Yeah,
Yeah.
hi, Wakas. Congratulations for that getting CESR as well. However, I have a question about the job plans. What does that mean, job plan?
Job plan is when if are you working in NHS?
Yes, I'm working in NHS.
Yeah.
Yeah.
So if you're working in NHS, then most of the trusts they give you a job plan when you start. Sometime it is on paper, sometime it is on online. The trust I work in, they give a job plan online which you sign. So it's simply a description of what you do. So
There is different from job description or the same because
it is all no, it is almost the same. So job description is a
because
summary of what you will do, and job
because in CESR here, sorry, in CESR here in domains there is job description and job plans. It's different, but I don't
plan.
know. Maybe the
Yeah.
same.
So job description is a summary of what what. So it's basically an advert in when they are going they advertise the job opportunity. So
Oh,
that is a few lines or a paragraph. But job plan is detailed that what you do, what is your rota, what will you be doing clinically, what are the admin PAs, what are direct clinical care. So when you are appointed or you work as a middle grade, there
mhm,
whatever amount of work you are working, so the 100% of that is not clinical. Some of that is admin, which include teaching, audit, quality, improvement, and all that projects. So
mhm.
so you can make a reflection on your job plan. Actually, that is a very good thing. So just open a new file in your portfolio and write on that job plan and put your reflection on that I joined NHS on this month and 1 year ago, and my job plan was this. And after
Mm.
1 year now, I have improved through this. I was not able to do whatever which you are
Yes,
hesitant with in the
I
start.
understand.
Now you
Okay.
are very competent in that, so that can be used as a piece of evidence.
Yeah. Just last question. There's a lot of things here in the domains actually similar to each other, like CBD record certificate, the same certificate of attendance of workshop or conference, the
Yeah.
same CBD registration points, the same. All of this the same. How I will deal with that?
Sorry, I didn't get your question. So CBD is CP. Are you talking about CPD?
Yeah. CBD record certificate, and then again they ask about certificate of attendance of workshop or conference.
So
Conference.
yeah, so that is basically the same thing.
Yeah.
Um, so CPD usually has to display CPD points on that, because some
Mm.
of the workshops or some of the courses you do don't display the C. For example, you are
CBD.
doing this
Yeah.
webinar today, so you
Yeah.
unfortunately you will not get any CPD points for that. So
Yeah.
yeah, so that is basically a difference, but they are one and the same thing, basically.
Okay. Thank you.
Yeah.
Yeah. Sadia Wakar.
Hello, Vakas. I'm Sadia. My question is for specialty Caesar. I worked in Saudi Arabia 12 years in infection disease, pediatric infection disease. My first question is that experience will count and these certificates can be added to this portfolios. Second, currently in UK for 2 years, I'm working in general pediatrics. So my hospital people say that you go for a Caesar pediatrics. My interest in the subspecialty, how I deal with that. Either I will start with the subspecialty or with the pediatric.
All right. So as regards to your first question that you have a previous experience, will that be counted or not? So you have a 12 years experience. So well done for that. But unfortunately, GMC will not recognize any experience more than 5 years. So all of your evidence you are going to submit in your GMC application should not be older than five years. So that counts from the point of application. So if you are submitting your application today, so whatever evidence you are submitting should not be older than 5 years. So that will not be entertained.
Okay.
So one thing is that. Second thing is whether you want to do CESR in pediatrics or infectious diseases. Again, you have to weigh and balance things. I mean, it's your decision, but it is not a bad idea to go for general pediatrics. If you are working in general pediatrics at the moment, it's much easier to get evidence of what you are doing currently rather than getting evidence for a different specialty. Unless if you would be working in pediatric infectious diseases, then it would be a different case. Other option is that you get a job in pediatric infectious diseases and go through that pathway.
Yeah.
Still, as I mentioned, for other subspecialties, you can do a general pediatric Caesar, and once you achieve that, you can go for a SPIN, which is a special interest module in different specialties.
Yeah, thank you, Vakas. This is the suggestions given to me by my department, because they say that we are easily going to assign your competencies because we don't have infection disease in our hospital. So they're happy to lead me to the general pediatrics. Thank you so much for your kind information.
No problem, no problem.
Atif Riaz.
Hello. Hi, Vakas. Congratulations for your successful application first. So I did SCPS from Pakistan, and I started some neonatology second fellowship there before coming here. So just want to say, but I was not using any e-portfolio for my evidence in neonatology. How can I write down things which I have done?
Yeah. So if it is not very old, so you can still go back to your institution or whatever hospital or your supervisor if it is not older than 5 years, and you can get that signed if if so. But you cannot get much of that because it's not only about the procedures and DOP. So there's a lot of other things in Pakistan. I worked for a long time ago, but it's not very easy to get evidence for communication. How did you talk to the families? There are no appraisal system there. What you can get from there is basically your domain. I think it's 2 or 3 that the procedure thing, that the procedures, which is very important in neonatology. So I have 2 or 3 friends who have completed CESR in neonatology. So, and with a very close friends. So DOPS and the procedure logs, you can get that from your hospital.
Yep.
And if you have done any publication, research, or audits in Pakistan, that will also be a good piece of evidence which you can use. And if you are working in neonatology now, then start your portfolio as keeping in mind that you are going to submit the CESR application in the next 2-3 years. So neonatology.
I'm in level 2 neonatology, sorry. So I have done
That's fine.
UVC, intubation I've done, and I have evidence from here, chest tube, everything, big light.
Yeah, that's good. So but that is not the procedure, is not on the only thing.
Yep.
They have to get evidence for quality improvement and communication, leadership, lots of meetings with the preterms, discharge planning meetings, neurodevelopmental follow-up of the preterms. You may also need the competencies for cranial scans and these things. So go through the guidance of neonatology. It is available on the GMC website, and prepare your prospective application in the light of that. CESR in neonatology is not very difficult.
Okay, shall we take rest of the questions after the presentation? Shall we go back to the presentation?
All right. Okay.
All right. Thank you.
Thank you. Okay. So let's go to, so now coming to the evidence, which is the most important bit of your application, and is the least information available, although there are loads of info, but it's difficult to digest sometimes. So first thing is quality, quantity. So there is no minimum or maximum. Again, GMC has been very vague on that in saying that they need 800 to 1000 pages of evidence. I don't know what does that mean. So that will look like this pile of files, if you can see here. Can you see that? Yeah. So can you see my slide? Yeah, okay.
Yes.
Yeah, so
Yes.
it will look like this pile of evidence, this amount of pages. The other thing, they say that it could be, it should be around 150 to 200 uploads. Uploads means soft copies of files. So it should be 150 to 200 uploads, which you have to upload. That's the quantity they are looking for on the online application. So earlier, when I opened my drive and showed you the folder, so in all the 11 domains, all the 11 folders, so that I counted that is somewhere between 150 to 200 files, which you have to upload. So so you keep that in mind, so that you will adjust your speed according to that. Now, next thing is get familiar with the domains. Again, that is very, very important to get yourself familiar with the domains, because don't keep getting evidence blindly, keep doing CBD every day. That will, so one, if you have lots of evidence in one area, that will not compensate for your deficiencies in another area. So that is very, very important. So you have to maintain a proportion. I'll come to that in the next slide, that what proportion do you need. Again, portfolio comes in. So that is a type of evidence which you can get without a portfolio. So see, there are lots of things you can get without having a portfolio. So portfolio is not a very, it's not mandatory. So what you can get without having a portfolio, you can get appraisals, you can have clinic letters if you do clinics, and transfer letters. Even if you don't do clinic, you must be doing transfer letters, because every hospital you need to transfer a patient from secondary care to tertiary care, from tertiary care to quaternary or whatever, or back to primary care. Safeguarding reports, again, that is a very important domain. Domain 9, I think. Yeah, domain 9. It is very important for safeguarding. So you must be having it. I submitted 6 or 7 safeguarding reports. So the safeguarding reports, for those who don't know, is a child protection assessment, medical assessment, when child comes to you with a history of abuse or maltreatment, and you have to do the assessment, and you have to document yours. It's a formal legal document, ranging from 10 to 15 pages. So you don't need a portfolio, and that is a very strong piece of evidence of your competency, and you can use that in more than one domain. Teaching and presentation, again, you don't need a portfolio for that. You do every hospital in anywhere in the world, you must be doing some teaching, some presentations, publications. So keep the record of your teachings which you have been doing, and get a feedback on that. So that is very important, because just giving GMC a PowerPoint presentation is not sufficient. You have to get feedback on that. So feedback you can obtain on your trust forms, or you can just use the Google Form, Survey Monkey, or anything like that. So whenever you do a teaching, get feedback on that. That is also a very strong piece of evidence. CPDs, you must be doing CPDs, so courses, APLS, NLS, other courses, leadership, safeguarding, lots of other things you need to you do as a part of your daily job. So that is an area which you you probably will not be deficient in. So there are lots of opportunities to do CPDs. They don't improve your application beyond a certain extent. So they are important, but it's not that you keep doing different courses in an expectation that your application will improve. So 3 of the important CPDs or mandatory CPDs are APLS, NLS, and safeguarding level 3. If you don't have that, your application will be rejected. Apart from that, you keep collecting whatever you get the opportunity for. Feedbacks and testimonials. Again, you in your appraisal, you take multi-source feedback from colleagues and from patients, compliments, cards, thank you card, greetings, lots of things. So you don't need a portfolio for that. Incident form, that is also very important. So domain 7, I think, yeah, for patient safety. And the evidence you can give for that domain is incident reports. So don't worry if you are involved in a 1 or 2 incident reports or DATIX reports. That is actually a plus point. So don't feel that that you are not I mean, if you have provided a DATIX report which you were involved in, for example, a sharp injury or drug error or whatever, and you have written a reflection on that you will not do that again, and whatever you have learned from that actually is a good piece of evidence. And what else you can do is to keep doing some incidents. So you will find the opportunities in your workplace in which you can register or enter a incident report that a drug error has happened or any safety issue has happened. So that is a very good piece of evidence. Audits and QIPs, again, you don't need a portfolio for that. So do audits and QIPs. That is a very, very important thing. So domain 5 or whatever. I submitted around 6 to 7 audits and QIPs. And mostly all of them I was the lead in, but you have to be a lead in at least one project. So lead means that you have started everything. So that's what GMC says. Publication. So not all of us are good in publication, and GMC and the Royal College acknowledges that so that is not a must thing for to give the evidence for research domain. And but if you have that, that's well and good, very good. So publications also take a lot of pages. If you have submitting a complete article, so one article sometimes it has 25-30 pages. Other forms of evidence again for research is case presentation in the conferences, posters, journal hiccup, or what do you call that, critical appraisal of an article. And then last but not least, the experience certificates, which all of us have, considering your wide experience. All right, so next is, one second. So type of evidence for which you need a portfolio. Okay, so this is where you need a portfolio. Work-based assessments. Work-based assessments are the supervised learning events. So you say that you have a 15 years of experience or 10 years of experience, but how is the person assessing you is going to believe that? So you have to prove through different processes, they will assess you, feed you back with their advice to improve or keep it up, whatever. And that is a very good authentic piece of evidence for CESR application. So what are the work-based assessments? CBD, which is case-based discussion, and you get a lot of hundreds of opportunities every day, almost, of these things. Yes, I agree that some trusts are supportive, and most of them they're not, and they are, because the consultants usually have a lot of other tasks, and whenever they have time, they prefer trainees over non-trainees sometimes. I mean, I know some of these issues. So case-based discussion, you see any case which you are the first primary physician or main lead physician, and you send a report or a kind of a ticket to your senior, your consultant, and he will feed you back with a reflection. Mini CEX is a mini clinical evaluation exercise. What is this? I can see a pop-up on what is that, Jamil? All right, okay. So ACAT is a
Note that.
okay. Acute care assessment, for example, is assessment of you when you are working in an acute situation. For example, in a theater for resuscitating patient, a newborn, or in emergency, a sick patient, asthma, DK, whatever. But the main thing is that you have to start, and then you can send a assessment request to your senior, and he will. That is also a very good piece of evidence for domain 6 of your application, which is leadership. Other ways you can do that, you can ask your consultant in the morning that please give me the consultant bleep. There's a consultant bleep hardly rings. So and you can do a reflection that I did a ward round today, and the ward is busy, and one of the junior doctor was absent, and you also did a teaching in between, and you managed nursing problems and all that, blah 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 blah. There are lots of opportunities for that. And then you can send this assessment to one of your colleague, not necessarily a consultant. You can send with that to a colleague with equal seniority as you. HAT or HAT is a handover assessment tool. So at least 3 times we usually attend handover meetings. Or maybe 2. So lots of opportunities when you hand over, you can ask your colleague to assess you. It's just a simple form, the S-bar thing, situation background assessment, how many patients in the ward, safety briefing, no patient with the similar names, safeguarding and all that. So it's a very good thing. It's a very easy thing. DOPS is a direct observed procedure skills, where again, which I showed you in the start. You can also get that done on a manual paper if you don't want a portfolio, or that is something you can get from your previous workplace if you worked back home, and in their lot. So that is something which we keep the record of. And next is doc. So doc is a discussion of correspondence. So that is a good piece of evidence which you used in the communication domain. So the clinic letters, the transfer letters, the all the written information comes in DOC. So you have to send it your assessor, and he will see that and give you a reflection or feedback that how can you improve that. So that is also not a very difficult thing to do. Safeguarding CBDs. Now this is a bit not very easy thing. So if you're working in a DGH in acute pediatrics, you will get referrals for safeguarding cases, and most of the time our trend is to avoid that, to keep away from that. But if you do a few safeguarding CBDs, that is actually not good. That is kind of mandatory thing in your domain 9 of the portfolio, which is safeguarding, along together with the safeguarding report. So that is very important. So make a note of that, because that is the area most of us are deficient in. And then the last is leader CBD, case-based discussion in cases which you have been a leader. All right. Okay, so this was the proportion. This was something I was talking about, that you have to maintain a balance in proportions of these evidence you make. So don't just keep recording logs of patient and procedures. That will help to a certain extent. So if you see this pie chart, left side, the red area is 50%. So if you have 1,000 pages of your evidence, 500 out of that should be of these three domains: communication, procedure, patient management. And 25%, which means 250 pages, should be on professional values, leadership, team working, and education and training. And 25% will be the green thing, which is health promotion, illness prevention, patient safety, quality improvement, safeguarding, and research. So you have to maintain not the quantity, but also the quality and the proportion, especially because, as I said earlier, deficiency in one area cannot be compensated by more evidence in another area. So if you provide hundreds, more evidence in patient management or procedure because you're good in that, that will not help. All right. So, okay, we'll stop there and then take some more questions and then move forward because again, there is a complex thing coming. Hafiz server. Yeah.
Yeah, thank you so much for providing us such a wonderful opportunity to make things easy for us. My question is regarding workplace-based assessments. How we can collect these assessments from our previous experience out of NHS while we do not have a portfolio at that time? How should we be collecting those?
Yeah, so that is the thing that that's something you cannot compensate for. So collect the previous slide which I showed you. I'll open that again. So for these type of evidence which you are now seeing on your screen, that for this you don't need a portfolio. So maximum of your previous evidence collect without, if you don't have a portfolio for that, so use this type of things, these tools for your previous evidence. And now you are working in NHS, so try use collecting everything through the portfolio. Hope that answers the question.
Yeah, just my query was in our SSG guidance, and regarding they say 2 CBDs every year, 2 mini CACs every year. Then what if I generate like CBDs covering for the last 4 years in next coming 1 year, because I am planning to submit application in 1 year time. Can I submit those number of CBDs ACAT during this year, or it should be dated previously as well?
No, okay. Are you talking about the training or CESR?
No, CESR.
Because CESR, there is no minimum number of assessments you have to have. At least it was not there when I was working on my application. So these 2 CBDs per year or 2 mini CACs per year, they are more of our trainees ARCP requirements. So you don't need a minimum or a maximum number of assessments per year. So you can create a mix of all this evidence in your application. So as I said, your previous first thing is that please keep in mind GMC will not entertain any evidence older than 5 years. So the longer you go, your previous experience gets less and less and less important. Because if you are submitting your application after 3 years and have you already been working in the UK for 2 years, so that means it's already been 5 years till that then, and your previous experience is almost null and void. Not null and void, but it will not be very authentic or not be any use for them. So whatever you have done in the past, hold it there, arrange under these categories of appraisal, letters, teachings, presentation, publications, whatever you have done, experience certificates in the past. And now what you are doing in UK, collect it according to the portfolio. Is that more clear?
Okay, next
Yeah,
question is
like
Amar.
just to make myself clear, if I will generate a number of CBDs, it doesn't matter when these were collected before submitting the application.
No, it doesn't matter. The CBD can be should not be more than 5-year-old from that point of application.
Okay, thank you so much.
Amar, please.
Guys, My question is how to link the CP, for example, the work-based assessments to our domains or curriculum. This is my main problem, to be honest. Because, for example, if I've done a CBD, for example, for safeguarding, and I went to safeguarding curriculum, I'm very tempted to tick most of the boxes in this one, in this domain. So what is the trick? Sorry. Thank you so much, Wakas, for doing this lovely session.
Yeah, so don't tick each and every box. So first thing is that Royal College says even if the trainees don't check more than 2 boxes in more than 2 domains in your CPD or any other work, any other assessment. So if you are doing safeguarding, then you can put first thing is a safeguarding. Again, there are if you open the domain, open the portfolio, there are 3 levels: level 1, level 2, level 3, and in each level there are further key capabilities. So it will be the discretion of your assessor who is assessing you that he will be happy with whatever you have ticked or not. If he signs that CBD, so whatever you have ticked will be accepted. Now, if you have done a safeguarding CBD, for example, so you put that in one domain could be a safeguarding domain, and other domain can be a leadership, or if you have done the CBD, if you have done the safeguarding yourself. If you are not done yourself, you can put that into communication because you are writing a report. If you are not writing a report, you can put that in patient management because you are managing a patient. The multiple things you can put that into.
All right. Okay. We've got quite a few hands up, Wakas. Do you want to go through the
Please,
questions?
because because that is the most important thing.
Okay. So the next one is Kulsoom, please.
Can I just, Hannah, also, I have been raising my hand for a long time.
Yeah, sorry for that.
Oh, yeah, Hannah, go through with it because I called previously your name, but I think we couldn't get through to you. Yeah, go ahead.
So thank you, Agas, for this presentation, and it's very clear guidance and very useful. I have 2 questions. Regarding regarding the safeguarding, when you are saying like we should give evidence of safeguarding reports, are you talking about the reports?
Yes.
Only, or the S47 pro forma? Which is the one we do whenever we see the patient's initial?
Yeah. Okay. So section 47 pro forma you don't need to share. That is that's quite a sensitive thing. So safeguarding report is your report when you have done. So for example, a patient comes to you with a fracture or a bruise, and you have done full safeguarding assessment, and there is a consultant with you or a senior colleague with you, and you have made your impression, because the preliminary report you make on the same day, but after the detailed report, which is 8, 9, 10, 11, 15 pages, depending upon the case, is ready after a week or so. So you dictate all your assessment right from the start to the end. What are the patient names, relative name, what is the mom, who were the characters in the event, father, stepdad, and what happened, and then witnessed, and then previous history, past history, and then you come to the conclusion that this injury is accidental or non-accidental, and what are you planning to do next, and you have already discussed this in the safeguarding meeting. So I unfortunately cannot share my safeguarding reports which I have with me, but that contains sensitive information, so that I cannot share here.
Okay. I have done 2 so far, like a medical safeguarding reports, but you advise for like at least more, 6 or 7, isn't it?
Yeah, that's what I did. Maybe they can accept a little less, but I think, yeah, if you are giving an experience, for example, 5 years, or that's what GMC looking into. So you are looking to provide at least one every year. So it's just an example. It's not a hard and
clear.
Not a formula.
And last question. We know when you attach your evidence in e-portfolio to the domain and the key capabilities, when I apply for a CESR, I should only give an evidence for level 3 only, right? I shouldn't. I'm not required. What?
Yeah, you can give evidence of level 2 as well, and I have submitted that. But you
sorry, I keep. What if I didn't give submit level 2 and level 1?
So get some evidences of level 2 as well. Level 1 is not required. but get some of the evidence of level 2 as well. It's not difficult if you are having a level 3 competency signed already. So level 2 will not be difficult. Or in the same case, you can put both levels, because some of the key capabilities belong to level 2 and some of them belong to level 3. So for example, if you are hosting a discharge planning meeting or something, if you are attending a meeting, then it is level 2. If you are leading a meeting, then it is level 3. So if you are leading a meeting, then also you are attending a meeting. So it will come in 2 and 3. So mostly it's level 3, but also give some evidence of level 2.
Okay, this is come to the last question.
Yeah.
So if I already submitted the evidence, have been signed by a consultant, but the evidence, the key capabilities are all level 3.
Yeah.
Can I go again back and add level 2 or no?
No. The one assessment you have done is done, so that cannot be edited. So you can use some other. There's lots of opportunities. So if you have get your competencies signed for level 3, it will not be difficult at all to get competencies of level 2. But don't worry about that. It is not that important as you are taking it to be.
Okay. Thank you very much. Thank you.
All right. Can I request everyone please to limit yourself to one question, because I've got loads of hands up. So everyone can get the opportunity to ask their questions, please. Thank you. Kulsum is the next one.
Dr. Ukas, the other thing is there are lots of questions in the chat which people want you to go through as well. So once this finishes.
So you want me to open the chat, or you will read out and then I'll go?
Yeah, I'm trying to read out and replying few of them, but few things they want you from.
Okay, so I actually my screen is different, so I cannot see the chat. I don't know.
Yeah, I will read through once you finish all these questions.
Okay.
I can read the chat for you. Yeah.
Okay. Kulsum, please.
Hi. Thank you, Dr. Ukas, for helping all of us. So the one question is that because I think I'm not understood properly this. So when we are doing portfolio and we have signed all the CBDs and AKIT, minikits, DOPS, everything, and so still is this needed? Then we have to have this discharge letter as well. What we made it. And the CP medical report, what I made it to put in the CESR report, like we are saying we have to redact it. I'm not getting this stuff. When we have a competency signed by a consultant already, why not only we can put in the CESR application that only, rather than going through back and finding out all what I made in the past, the discharge summary, whatever, ref transfer letter and correspondence, anything.
Yeah, okay. So yes, it's not important, but it is good that you provide evidence from different in the resources. So not only portfolio, clinic letter also, there are assessments in the portfolio called discussion of correspondence. And in that you have to send a clinic letter to your assessor who assess your clinic letter. So your verbal as well as written communication is one of the competency you need to achieve. Yes, if you have enough evidence for that, and you don't want to see the clinic to use the clinic letter as your evidence, although they are very good piece of evidence. I'll tell you why. But if you don't want to use that, that's fine. And the term redaction I'm using is in basically anonymization of the patient identified data, which you have to use in the portfolio as well. So you cannot simply attach a clinical letter in a portfolio and send it to your supervisor to see that. It is very, very important to anonymize your data. There is full guidelines on the GMC. So you can use a software and remove all the patient details, and that is called redaction. So if your evidence go to the GMC without that, it will be rejected. And I hope that, because confidentiality issues in this country, they're taken very seriously. So you will be trouble.
Yeah, I agree with you, Dr. Vikas. My question is this: like, sometime what happened that I'm working in my consultant clinic, and I already sent by email this letter. Already, it has been discarded and sent to the patient, and she knows what I did. Yeah. So usually, I don't upload in my portfolio letter. I just sent assessment, and she
It is
signed it. She
yeah.
verified, so I don't need to even redact that letter
No, it
or
is very
upload it.
easy. You go to your secretary and ask. They will bring all the previous 1,000 letters, whatever you want. And sometimes, if you have good relations with your secretary, she can redact that, or he can redact that for you as well. So clinic letters are a very good piece of evidence because they can be used in multiple things. So for example, they can be used in as a part of a multidisciplinary management, because if you are seeing a patient, for example, obesity, which you are sending to nephrologist for hypertension, endocrinologist for hormonal problems, and weight management service for weight control, or you are seeing a patient with any complex need patient, which you need to send it to a referral to occupational therapist, physiotherapist, sleep therapist, or speech therapist. So they can be used in multiple domains: patient management, MDTs, and communication. So that's not only correspondence. But again, that is not a compulsory thing. If you want, you can if you don't want to use them, it's fine. You can.
Yeah, because I do have some referral letters signed by my consultant, although I have not attached in my portfolio this letters, because she already had emailed this letter. I already emailed them a letter. They already corrected and sent by secretary by the page to the patient, or to the referral to the tertiary, like
Yeah, that's
other
fine.
specialty.
That's fine. It's not a compulsory thing.
Yeah, that's fine. Okay, yeah, this fine, my question. Thank you very much. Yeah.
All right. Abda, is that an history hand or is it a new hand? Abda Harfi.
Hi, Wakas again. Sorry, Mr. Bill.
Okay.
Again, just I want to ask: have you been ever asked about to give them any hard copy evidence?
Hard copy evidence, they will ask for your certificates, the experience, the qualification, and all your registrations of all the countries you have worked in. So that is something, even if you have worked for 20 years, so you have to give the registration for the whatever your licensing authority of that country is. So you have to give that in hard copy, and that has to be authenticated as well. That I will come to in my subsequent slides.
No, just another question. Just you mentioned that there is a lot of to and fro between you and them. Can you give us just some example of about why they?
I'll not. So I'll tell you each and everything, but
thank you. Okay, thank you.
that section is coming to.
Thank you very much.
Muhammad's hands up, please.
Yeah, hi, Dr. Wakas. Thanks a lot for this session. My question was, so I think you will be showing it on your slide, I guess, that the CESR application is basically through GMC Online. It has nothing to do with the RCBCH website, right?
No, it's a GMC online account.
Yeah. And I guess you'll be telling us about it later, that it's basically you upload it. You'll be telling us how to upload.
Yeah, I'll be telling you in my last few slides.
Yeah, okay. I think that'll be fine then. So yeah, sorry, then you can carry on. I think you should carry on, yeah.
Okay, so the last hand was up was from Chatra. I can't see it anymore. Does she have a question anymore or no more? Chatra?
I think she's left.
She's left. Okay, that's fine. Then we are done at the moment. No more hands.
Okay. So any questions from the chat, Dr. Sadia? Anything?
Yes, let me go through them.
Yeah.
So the first question was basically about CESR subspecialty, which you have already answered. And then the question was regarding the domains of subspecialty, and I've answered that it's just the general piece. We have 11 domains. Every subspecialty have their own domains.
Okay.
The next one is, so there was another question. Even for non-CCT, CESR domains are specific for each subspecialty. Do you tag and link the domains in portfolio before you upload them to your CESR application?
Yeah, so the non-CCT specialty, the domains are generic. I know some of them my friends have done in neonatology and other specialties. So they are 4 or 5 generic domains, which, the same domains as GMC, good medical practice. And linking, you have to do everything before uploading. So portfolio work is complete each and everything. Uploading is the final thing which you have to do. It's not, you cannot link or unlink after that. So when you finish your assessment in the portfolio, there is a tab up in the top right corner, I think, with at least in my portfolio page like that. Is download PDF, and you can download the PDF, and that PDF you can attach as an evidence in your GMC application.
And then the other thing is the date of birth accepted?
I rejected that. They said any patient identifiable data, so don't take a risk, redact that.
Okay. And then can you do CESR for working in community peds?
So if you are working, so obviously if you are working in another specialty and you are doing CESR for another specialty, that is not advisable, because obviously if you are working in a community pediatrics, you will not get these acute competencies and emergencies and neonates and all that. So you can work as a consultant in community pediatrics after doing a CESR in general pediatrics. That I can advise. So you can, if you have done a CESR in general pediatrics, you can work in emergency medicine, you can work in community pediatrics, and you can work in a level 2 neonatal unit. And yeah, so but working in a general pediatric and doing or working in community and doing CESR in an or vice versa, it's not advisable.
Yeah. And then another question is, I have evidence from my patients back home. I need a resume of each patient, or just a list sign out from my old hospital?
No. Resume, I didn't get that. I don't know what does it mean, but if you have evidence from back home, and if it is as long as it is not less than more than 5 years, you can use that. If it is a logbook, then you can use that after reduction of patient identifiable data.
Then is, if you get CESR in general peds, can you apply for consultant job in any other subspecialty?
As I said, level 2 neonatology, community pediatrics, pediatric emergency, but not other than these.
Okay, for the competencies, do we need only consultants to sign the competencies? And you've already answered that.
Yeah, preferably, or if you don't get anyone, then you can get your colleague to sign that, or a senior registrar, but you should have a mix of everything in your application.
Yeah, and so actually I double checked this with because I'm already working on it as a consultant. So when I'm doing the procedures, I was struggling to get someone to do my DOPS. So I checked, and they said anyone like who is capable of doing that procedure, like ST67, and if they are around you, they can do it for you.
Yes, they can. Yeah.
And then,
so, but the thing is that it's only about, not only about DOPS, there are other things as well. But anyway, yeah, the best thing is to get a mixture of everything in your application.
Okay, and then how to collect evidence before starting an application? Should it be on hospital letterhead or signed by someone?
I mean, you have to collect evidence anyway before submitting your application. You cannot submit your application and can collect the evidence later. So what is the question? Letterhead or whatever? Yes, letterhead is important. Letterhead is important. Let me show you one example. I'm going again back to this.